My name's Chun Fong. I'm a hematologist that works at the Austin. I'm the medical lead for acute leukemias and myelodysplasia. I also have a couple of other hats. I'm a clinician scientist fellow at the Olivia Newton-John Cancer Research Institute. I'm also a molecular hematopathologist at Austin Pathology. So a couple of things that I do. ALL, or acute lymphoblastic leukemia, is a very aggressive blood cancer. It predominantly affects younger patients and involves a lot of therapy. One of the big things about ALL is that it's a success story for modern oncology, where it was previously fatal. Over the last 50 years, we've gotten to a point where the majority of younger patients have an excellent survival. It is something that we continue to work on, and those patients that are older or have other issues have access to lots of new therapies that are coming on board. AML, or acute myeloid leukemia, is an aggressive cancer of the blood and blood-forming organs. It is a cancer that predominantly affects older people, and the treatment is very aggressive and can be very successful. But there are a number of challenges that acute myeloid leukemia patients face, and they're things that we work very hard on in multiple clinical trials and ongoing international research. The biggest game changers in my field over the last decade have been the advent and application of new technologies, especially next generation sequencing technologies. These technologies have opened the floodgates, opened our eyes to underlying disease biology, given us an enormous amount of information and detail, targets to aim for in the treatment of acute leukemias, and in particular acute myeloid leukemia. Off the back of the knowledge we've gained from these new technologies, we've had new targeted therapies that have just come online, including one that is now PBS reimbursed in Australia. It's been an incredibly exciting time to work in acute myeloid leukemia and the acute leukemias in general. A number of drugs have been very successful in acute myeloid leukemia in the last 2 or 3 years. Two drugs come to mind. One is a drug called midostaurin, or Rydapt, and this is a targeted therapy that targets FLT3, or an abnormal protein that is activated in a significant subset of our patients. We now have access to this drug on the PBS, and this drug has, in combination with a high-dose chemotherapy, been the first time where a targeted therapy has demonstrated a significant improvement in patient survival in acute leukemia. The other drug is a drug called enasidenib. Again, it targets a protein that is abnormally functioning in leukemia, and this new drug is FDA approved, not available for routine use in Australia, but going through extensive clinical trials. But again, is a very promising drug with a single agent being very effective in controlling leukemia. Very active clinical trial space in acute leukemia, acute myeloid leukemia. We have had a slew of drugs that have gone through what is FDA breakthrough designation, which means that these drugs are incredibly promising, and they're being fast-tracked through clinical development to get it out into routine use. So one drug is a drug that has a very strong history in Melbourne and in Australia. It's a drug called venetoclax. Other drugs, there are two others that that have this FDA breakthrough designation, and they're drugs that we run in clinical trials at Austin Health and the Olivia Newton-John Cancer Research Center, and they look to be very promising. So the other drugs are prexinostat and a drug called uproleselan. Because a number of our patients with AML tend to be older, they're not really fit enough to go through very intensive chemotherapy. One of the drugs that has been used in this situation is a drug called Vidaza or azacitidine. It's a drug that's been proven in this context, and it is low dose. It's injections under the skin that is given for 7 days out of every 28 days, so a week out of every 4 weeks. It is a gentle therapy, but an effective therapy, and it has the ability to control the leukemia and give some reasonable quality of life. Its main side effects are as a result of nausea or injection site reactions. So it is an injection under the skin, and some people can have some redness and itching at the sites. Beyond that, the patients that I've had on this therapy tend to tolerate it very well. And that's very fortunate because patients tend to receive it over an extended duration if it works, and some patients may be on it for years. One common question that I get that is usually faced by patients when I tell them about their diagnosis is, how did this happen? Why me? And it's a difficult question to answer most of the time, and one of the reasons why I work in this field is that patients haven't done this to themselves. It is something that has been an unfortunate situation arising from bad luck. The deeper answer to that question is rooted in biology and an understanding that in each one of our cells we've got 2 meters of DNA that gets packaged into a very, very tiny little nucleus. And every time we make a new cell, and we make about 10 billion of these new cells every day, 2 meters of genetic information needs to be copied exactly. If we make a mistake, sometimes, well, most of the time, it's recognized by the body, gotten rid of. Sometimes one goes through to the keeper, and that can result in things like blood cancer. So it is unfortunate, it is bad luck, but that's my job is to try and change that luck and improve their outcomes. I think it's really important for patients, their families and their carers to understand as much about the disease that they're facing as possible. There are some good places to get information, there are some very bad places to get information. I think high quality information is something that a lot of effort has gone into from multiple sources, including places like the Leukaemia Foundation. I generally encourage my patients to ask me any questions to begin with. Then I point them in extensive resources that are found on the Leukaemia Foundation website. And then beyond that, I tell them to avoid Dr. Google at all costs.